And we often are criticized when we talk about, as in within my specialty, when we talk about sexual health, about overly focusing on fertility, because sex is something that people should enjoy, and of course sex is something people do to have babies. But I think it would be really remiss to not mention the impact, to try and bring together sexual health, diabetes, and talk a bit about fertility, menstruation, and the menopause. So specifically because we know when it comes to fertility, if you have diabetes, or certainly if you have polycystic ovarian syndrome, there's a higher chance, particularly if your diabetes isn't well controlled, of struggling to fall pregnant in the first place. And then when you do fall pregnant, there's a higher chance of experiencing pregnancy loss in terms of a miscarriage. Miscarriage is extremely common. About 1 in 4 people who fall pregnant will have a miscarriage. It again is a very stigma-laden subject, so you don't hear about it, but it's very, very common. So when you have the added element of diabetes and polycystic ovarian syndrome, there's additional nuance and sensitivities in that area. And then when you do fall pregnant, and hopefully the pregnancy carries till term, pregnant women who have diabetes will require additional support from their obstetricians and their diabetic teams to make sure that pregnancy goes well, because there are complications specifically for the mom and the baby in pregnancy that are wide-ranging that I won't go into today. Now, with menstruation, that particularly is focusing on PCOS, polycystic ovarian syndrome, where you can have anything from extremely heavy periods, which are less common, to no periods or irregular periods. And again, what people find, particularly with polycystic ovarian syndrome, is that with better control of their body weight and better control of insulin resistance, that can be normalized. Now, there is no direct link between menopause and diabetes. So being diabetic will not increase your chance of going into an earlier menopause. There's not strong evidence for that. But I touch on menopause because, if we think back to the education we got in school, which for many of us was nothing, and even in university, we will spend majority of our lives in what I call the perimenopause or the postmenopause as women. So on average in the UK, the average age of menopause is about 51. So you can start to experience perimenopausal symptoms as early as 35. Let's say you experience it from 40, okay? And what is the average life expectancy for women in the UK just now? I don't know, I think, is it?
About 85, something like that.
There we go. So essentially, 45 potentially plus years of your life in the perimenopause stroke menopause, and we are not talking about it. And this time in your life is very important for many reasons, but thinking about things biologically and physically, there are physical changes one goes through. You start to have a slightly increased risk, particularly postmenopausally, of heart conditions, and some of the manifestations of the menopause overlap with some of the urogenital manifestations in people who have diabetes. So, for example, the vaginal dryness and discomfort, the lower sex drives, and also not really an increase in urinary tract infections, but an increased sensation of cystitis. So this is something that we all need to be aware of as service providers and service users, because it is possible that quite a big chunk of people with diabetes are either perimenopausal or menopausal. So that really has to be front and center when we are providing care, essentially.
Absolutely. And can I just direct people to Diabetes Africa YouTube channel, because we've done a Diabetes Health Matters on gestational diabetes, so diabetes in pregnancy. So in terms of the fertility aspect, which, as we know, we can spend a whole webinar on that. So I just want to direct you to that. So thanks so much.
Yes, I'm going to check that out, definitely. Now, something I think we should talk about is myth busting. There are loads of myths. So I want to first of all say myths are, people often think of myths and it's all primitive. No, you just need to think of myths as the way we make sense of our lived experiences and our environments. And I think when you think about it, that you can understand why these things show up. And it's just about having that sensitivity and understanding and curiosity, I think. So here are some of the myths I've come across within some of our communities. So first of all, that in African and Caribbean culture, we're not meant to talk about sex. So I always ask people when I've heard this, what do you mean by African and Caribbean culture? So these are huge parts of the world, extremely with wonderful cultural diversity. There is no one culture. I think you have to meet people where they are and be respectful of whatever their individual personal values are. But sex is absolutely an important part of our well-being and health. So I personally believe that that's something we have to talk about. I've also heard people say things like, if you have diabetes, you can't have sex because you'll get hypo. I always wondered, perhaps maybe this is in the context of, if with increased physical exertion with sex, in theory, there is a possibility, particularly if you've not eaten, and, you could have a hypo. So I don't think that's an unreasonable myth, but I guess it's not a given. You will not have a hypo every time you have sex, but you should be aware as somebody with diabetes, particularly if you're insulin dependent, about what your blood sugars are around that time. It might be a bit annoying that you might need to plan a bit more, but this shouldn't be something that puts you off. Also, no such thing as sexual health, no such thing as being too old for sex, okay? That is something I stamp on all the time. Sex is for everybody who wants to engage in sex. There's also this myth that being diabetic predisposes you to sexually transmitted infections. Have you heard that before, Dr. John?
So, I think as with all of these, that sometimes there's a grain of truth. But then when the message gets transmitted to multiple people or through multiple people, it gets distorted. So I think maybe what people are thinking about is if you have hyperglycemia, if you have a high blood glucose, it's going to make you more prone to infection per se, whether that's a urine infection, whether that's a thrush type of infection. Some people have regarded thrush as a sexually transmitted disease, although we know that it's not. That's not the case, but some people have put it in that context. So I can see how you can conflate all of that, and then this myth has become that you're more prone to sexually transmitted infections. I think that's probably where it's come from. As with with the sex and having a hypo, again, maybe somebody who has mismatched their treatment to their activity has developed a hypo, and again, the message is transmitted through people, but then it gets a bit distorted. I love the one about sexual health is not for old people, because I can tell you categorically, as a primary care physician, I've had 90-year-olds come and ask me for treatment for erectile dysfunction. Sexual health is part of their health. It was important to them. So you cannot categorize people by their chronological age. So yeah, I love your myths.
Yeah, let's keep debunking them. Another one I've come across, perhaps not just with diabetes, but any chronic illness. And again, I think it's a manifestation of maybe sense making, or how we make sense of conditions. So, that if you have diabetes, it means you've been cursed or hexed. Absolutely not. For many people, diabetes, there is a genetic hereditary element. And then for others, there is also a lifestyle element, which to a certain degree can be reversed. But you have absolutely not been cursed or hexed. But it is a difficult chronic condition to live with, but not impossible. And many people live very healthy, balanced, successful lives with diabetes and polycystic ovarian syndrome, so not a problem. And again, another myth that probably relates to our earlier discussion about fertility. If you have diabetes or PCOS, you are automatically infertile and can't have children. Absolutely not. And actually, some of the I assisted the birth of a woman a couple of weeks ago, and she mentioned about how, because she had PCOS, she pretty much was not having periods for years and just didn't think she could fall pregnant. And there she was having her first baby in her mid-30s, very happy. But again, you can fall pregnant. It might be more challenging, but you can absolutely fall pregnant. And my all-time favorite one, because it comes up in a lot of contexts, not just diabetes, you can't fall pregnant if you have sex during your period. You absolutely can. And again,
Yes.
I have assisted the birth of many babies who were born through this circumstance. So yes, these people keep me in a job. So again, in many ways, I'm grateful. But yeah, so that
with the polycystic ovaries, just to say again, as a primary care physician, quite often people would be absolutely dismayed and dispirited with that diagnosis, and I understand that. But what I used to say to them was that, you know, it may make it a little bit more complicated for you to become, it may make it, because it's not inevitable, for you to become pregnant if that's what you want, but it's not impossible. It's absolutely not impossible.
Absolutely. And when you look at the cohort of people who have polycystic ovarian syndrome, majority of them, you know, who have tried to fall pregnant will fall pregnant. It's just like you said, when you compare them to the population who don't, they just struggle a bit more. So absolutely. And then now I guess focusing a bit on the management specifically of, you know, the various manifestations of sexual dysfunction in women who have diabetes. So like anything, you know, I think the absolute key is to take a really big holistic care approach, you know, with this person at the very center of your care. So what are their priorities? What are their ideas? What have they tried? And the key, I think, for holistic care is really about knowing as much as you're willing to know and learn. So a huge element in self-education. And this is something, you know, people who have diabetes are excellent at, because they have lived, this is a lived chronic condition. So they will often know much more than so-called experts. And I always say to patients who come and service users who come to see me in clinic, there is no way I will ever know more about your body than you. It doesn't matter how many years of medical school or what extra degrees I've done. You are always more of an expert in your body. You might not know the nitty-gritty biochemical genetic stuff, but you are always more of an expert. And I feel that we should empower people to believe that and, you know, take that ownership of your health. And a big part of that is community, you know. Community is so important for us, and we cannot exist out with our communities, and in that way we should build health in our community, and part of that is the dialogue and discourse around health in this space.
Yeah, and can I just say that, I mean, when we did the Diabetes Health Matters on erectile dysfunction, we said this is not just for men, this is for everybody. And I think I'm going to say this, you know, again and again. This is not just for women, this is for everybody, this webinar.
Absolutely. Yeah, such a key message. So I guess specifically in terms of the types of management, a big part of that is, you know, our lifestyle. So we want to all be aiming to live as healthy a life as we can. And specifically with diabetes and sexual health, this involves paying attention to your weight. I have a bit of resentment for the so-called body mass index.
Yeah.
Oh yeah, you do as well. So, you know, it's a number, you know, is it valid in certain communities? I don't know. I'm not sure. I think what is important to pay attention to with your weight is how much weight are you carrying around your core? You know, so the weight we carry in our tummy area, this is called a visceral fat. And this is fat that is metabolically active. So this is the kind of fat that it will increase your risk of conditions like diabetes, certainly poor control of your diabetes, poor heart health, high blood pressure. You know, this is a reflection of cortisol. This is how your body's processing the stress hormones. So I think it's important to, you know, look at your body. You know, I am very pro body positivity, but look at your body and just take a step back and see, where am I carrying this excess fat? If it's in the tummy area, not because we all want bikini bods or whatever nonsense, absolutely not. It's that this is the visceral metabolic fat that will get us. So that's what we should aim to lose. I don't pay too much attention to scales or BMIs, but that's me.
So I just say about the body mass index, it's a useful tool if you recognise its limitations. It's a very blunt tool, and we recognise that. So it can be useful in certain contexts, but yeah, we absolutely understand. And it, as you said, it is about that visceral fat. And again, you know, a sort of less sophisticated way of us estimating that is our waist circumference, or where you're carrying that excess weight. So yeah, recognizing all of those things.
And in your practice, what are your thoughts around? Because there's some thoughts around the different BMI categories for people by ethnicity. That's one that I haven't quite made up my mind about. What do you think?
So I think because of the increased risk of development of particularly type 2 diabetes, there is a lower BMI suggested for the different communities. And we do have to separate the communities. So you separate the South Asian community, you separate the African Caribbean, so-called Black communities as well, and different category of BMI for those different communities. So you can't say BAME, don't say that ever. So yes, but we can use that blunt instrument, that blunt tool, but to give us an indication of if you're at risk.